Welcome, everyone. This is part two of a webinar with Dr. Joel Blumin, where we will answer the questions that we weren't able to get to live at his webinar. So thank you, Dr. Blumin, for being here again and taking some more time to respond to these questions.
Thank you for having me.
So we will just jump right in. So one question is, I have adductor spasmodic dysphonia and tremors and getting shortness of breath, tightness when I talk. What treatment can help, if any, except Botox?
Botox is really the mainstay of treatment. Most patients are effectively treated with Botox or botulinum toxin, which would be the generic name. There are a variety of treatments available. These range from voice therapy. I usually tell folks that voice therapy tends to frustrate both patients and speech pathologists because it overall doesn't work that well. That said, it can be useful for specific issues that you have with your voice to help modulate or work with what you have. It won't cure the dystonia, but it can help you use what you have a little bit better. There are medicines by mouth. There's never been a good clinical trial on some of the medicines that the neurologists will commonly use, things like benzodiazepines. So we don't specifically typically recommend them, but some patients do get relief from benzodiazepines. And then there are operations. I happen to do some of these operations. They're really for very specific patients, and it'd be hard to generically tell you that you are a candidate or not a candidate for these operations. But they're all, the way I see them as they are alternatives to botulinum toxin. And frankly, the people who best respond to these operations also did respond to botulinum toxin at some point. I hope that covers that.
And typically for those surgical procedures, if you have a mix of, say, adductor spasmodic and tremor, would you still be a candidate, or is that
Yeah, so
limiting then?
So the most of the operations don't really cover the tremor component. So if the tremor is a mild or a minor part of what's going on, and the problem is really dominated by the dystonic contractions, then an operation may be okay. But if tremor is really the main bulk of what's going on, then the operations are really not appropriate because they don't treat the tremor.
And kind of sticking with tremor, does tremor respond to botulinum toxin injections?
Not as well as spasmodic dysphonia. Tremor, I usually quote 60%. I'm sure it varies, but tremor across the board really does not respond that well to a lot of treatments. Most patients, the most papers are somewhere in the 50-60% range, which is not, unfortunately, much better than a coin toss. The goal with tremor is really to I use the term to modulate or improve what you're doing with your voice. We really don't have any procedure, medicine, et cetera, that will make the tremor totally go away. So we're usually trying to find ways to make it work or make it not work against you, or make it work better for you. And again, the full range of options, voice therapy. There are some medicines by mouth for this that are specifically anti-tremor agents that some patients get benefit from. Botulinum toxin and actually operations, but operations really rarely perform for this and not specifically recommended.
How about when somebody has, say, adductor spasmodic dysphonia and tremor, and they respond well with botulinum toxin injections for the spasmodic dysphonia, and people will often say, "My tremors got worse." Is that really it got worse, or more that it's now more prevalent because the other spasms have gone away?
Yeah, I think the latter, that is just more noticeable because the tightness was fixed, but the bounciness of the tremor was not.
Okay. Is that kind of how you define it? Tightness for ADSD and bouncy for tremor?
Yes, except there are some patients with tremor that can have tightness as well. And I actually, though, that sort of goes to how we treat it. When I see a patient with tremor, I try to figure out what the most dominant problem is. Is it the bounciness? I usually liken it to speaking while you're jumping on a trampoline, or is it the subsequent tightness that folks can get as well? And when we treat one versus the other, we're actually targeting different muscle groups. And there's more of sort of figuring some of that stuff out with tremor than we do with spasmodic dysphonia. Spasmodic dysphonia primarily is a laryngeal overclosure problem, meaning your voice box is too tight, and we need to make that loose. Whereas tremor, you can have too tight, and you can also have bouncy.
Gotcha. Perfect. And what factors would lead you to send a person with a vocal tremor to a neurologist for an evaluation?
I actually recommend all patients with tremors see a neurologist. That's because from working with my neurology colleagues, they will say that some patients with tremor will have a treatable reason for that tremor. Now, the reality is, at least from my side, is that that's not very common. Most tremor is what we call idiopathic or essential tremor, which is well, it's what that term means, meaning that we don't have a cause, and ultimately we treat the symptoms. But I said there are some versions of tremor that are associated with treatable diseases. And those are the ones that the neurologists want to see and treat. Because I am not a neurologist, I will basically tell all my tremor patients to consider seeing a neurologist to identify one of these treatable disorders. The reality is I don't know, or I can't recall off the top of my head the last time I sent a patient to the neurologist that actually did where it was diagnosed with one of these. The great majority of folks do have essential tremor associated with vocal tremor, but I do recommend they see a neurologist. It is not actually true of spasmodic dysphonia. With respect to spasmodic dysphonia, laryngeal dystonias, those tend to be or can be idiopathic, meaning we don't know what causes them, and isolated, meaning not associated with other diseases. So there maybe isn't a necessity that the patients with SD alone need to see a neurologist. And in fact, most of the patients that end up seeing a neurologist before they see us, at least in our system, the neurologist will send them over to us to treat because they don't treat them.
And how about working with a speech language pathologist?
All our patients see a speech language pathologist as part of their initial intake and evaluation. I say intake, it sounds kind of funny. As part of their evaluation. And we do talk about therapy. If patients are interested in therapy, as said, with the caveat of the goals that I said before, then certainly they can pursue that. There are some patients who also, as they are being treated for their tremor, spasmodic dysphonia, that with, say, Botox, that I'll identify some issues that maybe would be better treated with therapy, and I'd refer them to therapy.
And similar, like muscle tension dysphonia is usually treated primarily with voice therapy, I should say.
Correct. Yes. I'll use the term voice therapy, speech therapy interchangeably. This is a whole other aside, but speech language pathologists probably need a better name for what they do. Most people think that, or I think speech language pathologists come from the term where they're all experts in how language is generated when we speak. But a lot of speech pathologists also do voice therapy and things like that. So I tend to use those terms interchangeably, whereas a speech pathologist might use one versus the other.
Gotcha. So this is kind of an interesting question. Is the word spasmodic in spasmodic dysphonia relating to the spasms or spasmodic in occasionally? Or both?
I believe, and we could probably ask Dr. Blitzer. So Dr. Blitzer and Dr. Brin, and hopefully I'm stating this correctly, actually coined the term spasmodic in the 80s. I believe before then, some people referred to it as spastic dysphonia. But Dr. Brin, who's a neurologist, Dr. Blitzer, who's a laryngologist, recognized that there weren't really discrete spasms like muscular contractions that we see in other diseases associated with what we call spasticity. There are spasticity means something specifically to a neurologist. So they coined this term spasmodic to mean that it is like a spasm, but it's not the same as a spasticity. Hopefully that makes sense. But my understanding is that this term was really coined for this diagnosis because it was similar, but not the same as other spasticity.
Interesting. Yeah, I think a lot of people are happy that the medical community moved away from spastic dysphonia. So, and how does spasmodic dysphonia fit into the overall field of laryngeal dystonia? Because we know a lot of our researchers are now referring to spasmodic dysphonia as a form of laryngeal dystonia or laryngeal.
Yeah,
Not
I
sure which
think
one it is.
I think well, spasmodic dysphonia I think has always been identified as a focal dystonia of the larynx. So dystonia refers to a specific type of motor or muscle problem, again in the neurology type of lexicon, and we've always called it that, but we gave it its special name of spasmodic dysphonia. I think as we recognize that there are lots of different flavors of spasmodic dysphonia, there could be respiratory spasmodic dysphonia, abductor, adductor, things like that. That as a physician, we want a more, I guess, appropriate global name for this disorder. So laryngeal dystonia really makes sense. It's a dystonia of the larynx. Spasmodic dysphonia is really a type of laryngeal dystonia, but they're fairly interchangeable. Laryngeal dystonia just also sounds a little more medical than spasmodic dysphonia, which is again, it's a specific coined term for this disorder from the 80s.
And can you talk a little bit about respiratory dystonia? We don't really hear too much about that.
It seems to be a type of dystonia or discoordination of the either the larynx or the respiratory muscles that are associated with respiration. Dystonia is referred to muscles not doing exactly what they should do when they're supposed to be doing something. So some patients can have their vocal folds should be open and relaxed when they breathe, but sometimes they could be out of sync with things.
Okay. And can you have respiratory dystonia and spasmodic dysphonia at the same time?
Yeah, I believe so. It's the respiratory dystonia is not very common.
Okay.
Yeah, yeah, but they're versions of the same thing. So I would say yes.
Okay. And how about there's a question about laryngeal spasm, and what is that?
Hmm. That's another sort of kind of a big topic that encompasses a lot of flavors of disorder. Laryngeal spasm, in and of itself, means what it sounds like: the whole larynx or whole voice box spasms, and typically it spasms closed. You can have isolated laryngospasm, where you choke on something and your voice box rapidly closes to protect your lungs from things going in. That's actually why we have voice boxes, is to protect our lungs from, I always say, foreign invaders. So you can have a very acute sort of rapid come on event that lasts not very long and goes away. Some patients have these as isolated rare problems. Other patients have a similar version that comes without a trigger, let's say, and can be frequent problems that happen all the time. There's versions that I answered earlier with this topic that somebody raised called vocal cord dysfunction or paradoxical vocal fold motion disorder or inducible laryngeal obstruction, where some patients have these types of problems, maybe to a milder degree when they're exercising. So laryngeal spasm kind of covers a lot of different things, but essentially means the voice box is closing when it shouldn't be.
And is there treatment for it?
Yes, absolutely. Most patients with laryngeal spasm, we will modulate or treat the triggers if we identify them. So if somebody's choking on something, we would evaluate what's going on with their swallowing and why they're choking, and perhaps treat that. If it's coming out of the blue, there are ways on the speech therapy side. Again, this is not speech therapy, this is actually breathing therapy that our speech pathologists do, where they can train patients to recognize that this is coming on and reduce the impact of it. For those this happens with exercise, also the speech pathologist can teach them essentially how to breathe while they're exercising so that this doesn't trigger.
Okay. And can you have spasmodic dysphonia and laryngeal spasm too? Are they
Sure.
connected at all?
They're not really, I would say they're mostly separate problems. As I describe them, they sound very similar, but I don't see patients that have that as an overlap type of issue. I'm sure it could happen, but
Okay. And a question, it's kind of a surgical question. It's is cutting a piece of the vocal cord a frequent way to treat a patient with dysphonia?
no. um, so dysphonia refers to problems with the voice or talking. You need intact, or you need vocal cords to vibrate to create a sound. So removing some of that wouldn't be the case. Now, depends on what you're actually asking. If there's a bump in the way, a nodule, polyp, or whatever in the interrupting the way your vocal cords vibrate and come together, then we would remove that. And essentially, that's sitting on top of the vocal cord, so we're actually cutting into the vocal cord, but we're not really trying to remove bits of vocal cord. There are procedures where we do remove parts of the vocal cord, mostly to improve the breathing aperture that our air goes through when we breathe. And we usually try to, when we do that, we try to confine our operations to the parts of the vocal cord that are less responsible for talking, to preserve talking and voice. So we definitely remove parts of vocal cords for breathing issues. We'll remove parts of vocal cords for cancers and things like that. But unless you're removing a lesion or a growth, we're not usually removing it for voice.
And now there are surgeries for spasmodic dysphonia, but you're cutting nerves. Is that correct?
Correct. Well, there are a few different operations. The more common operation, I guess, in the U.S. is the SLAD, selective laryngeal adductor denervation and renervation, and that is a nerve muscle operation. There are some other operations that are being done, like thyroplasties, where you manipulate the shape of the voice box, or the myomectomy, where you cut muscle. Myomectomies can be done through the voice, through the throat, which you're actually going into the top of the vocal cord, but you're actually going through the way side of the side more. I'm trying to think how to describe this. The we call it lateral, but the lateral, or the side of the top of the vocal cord, which is not involved in talking, but we do go through the lining to get there that way.
Okay. And another question will kind of circle back to botulinum toxin injections. Um, One of the questions is, when is Botox suitable for dysphonia? So I'm not sure if it should be spasmodic dysphonia or just dysphonia in general.
So botulinum toxin is a medicine that reduces muscle contractile strength. And so in laryngology, we commonly use that to reduce the closing forces of the voice box. So if you had a problem like spasmodic dysphonia, where your voice box is too tight or intermittently too tight, then that's when we would use Botox, botulinum toxin. And I said that's the mainstay of treatment really for adductor spasmodic dysphonia.
And is there a difference in outcome with the injection, for example, through your mouth versus the outside of the throat? Because maybe you can actually, I'll take it a step back. Maybe you can
Mm-hmm.
talk about a little bit about the different methods of injection. Because another
So
question is whether or not you should use an electromyograph too.
So there are a variety of ways to get Botox into the place you want to get it to. Now it's all injections because we have to place the medicine into the muscle. So you have to somehow inject it into there. Now you can inject it through the skin of the neck, which is the way I commonly do it. You can inject it through the lining of the throat, and you can subdivide that. As actually, you can do that by basically having the patient open up and say ah and go through their mouth with a very long curved needle, or you can do it through their nose with a telescope that's flexible, some other technology. But basically, both of those techniques, you're delivering the medicine through the lining of the throat to get to that muscle. When you're looking directly through a telescope, like through the lining of the throat, then usually EMG does not come into play because you're looking where the needle's going. When you go through the neck, some folks, or I should say even many folks, use EMG as a way to verify that they're in a active muscle. The EMG is a machine that makes a noise when muscle twitches. I happen to not use that. I was trained with a technique which is purely based on anatomy. So I touch patients' necks and feel the landmarks of their voice box, and I'm able to target the medicine into that correct compartment without an EMG machine. So an EMG machine is not used, or not necessarily not necessary to be used, but it is commonly used. I will say that the technique that I use and that I was trained for is a little difficult or a little bit harder to learn than when you have an EMG. EMG improves the learning quicker because you have the feedback of this sound. So the technique that I use may be a little harder to train, but once you learn how to do it, it's fine. Uh, as far as I know, there's only one paper. I happened to write it, which compared different techniques. I wrote this with Dr. Marati, my colleague who's now at University of Washington, and there was no difference between two different techniques. But for the most part, in our literature, there aren't good comparisons of one versus other. And as far as we can tell, they all work. Usually it's up to the comfort, confidence of the surgeon, of myself, or whoever's doing the injection, and obviously what the patient wants. I have had patients who have requested me to do a technique that I don't commonly use. And if that's the case, I know how to do them all. I just prefer one way just because it seems to work well for me. It's honestly, it's the way I use ends up being quite quick and relatively painless, not really painless, but less pain or discomfort than some of the other techniques. And that's why I do it.
And in some cases, we've heard of people who've actually gone into the operating room for botulinum toxin injections. I know that's not common, but can you speak
Yeah.
a little bit to that?
I sort of shed a tear when I hear that. It's not something that most active practicing laryngologists do because we just are pretty good at delivering it in the office. That said, if you have somebody who doesn't typically treat patients with botulinum toxin, doing it with techniques that we use in the operating room is perfectly legitimate, and there's nothing wrong with it. The sort of real issue is, I would say, is it necessary? Because most folks that do the things that I do know how to do it in the office. There are, of course, also exceptions to everything. And have I injected a patient in the operating room? I have. The patient was quite overweight, and I couldn't get a needle through his neck because it was quite thick. So that was the exception. So exceptions always happen. That's the nature of medicine. That's what we train to do. It's pretty easy to learn how to do, or I should say easy, but it's pretty straightforward to learn how to do everything that's sort of in the middle of the textbook. But when things are not exactly in the textbook, that's where all our training and background and experience comes to play, and we learn how to sort of shuck and jive and do things differently.
Well, that's also how the new procedures come to life, like the surgical procedures and
Correct.
such.
Yeah.
It's a lot,
Mhm.
through that kind of process and such. So great, thank you. Anything else you'd want to add about botulinum toxin injections as far as like for success or things to kind of keep a lookout for?
I think for most folks, they're quite successful for spasmodic dysphonia. Talk to your physician, surgeon about your experience. So we very much depend on, for dosing, we very much depend on your feedback of what happened. What did you experience? Did it work for you? If it did, how did it work for you? If it didn't work for you, absolutely, I want to know how it didn't work for you. Did it not work at all? Did you have too much weakness of your voice, or too much Minnie Mouse voice, or things like that? And if that's the case, then we will adjust the medicine, or the way we dose it, or the way we target those muscles. But I definitely need that feedback to give you the best results. Botulinum toxin is a titratable medicine, meaning we're always adjusting it up and down, or we can always adjust it up and down to give the best results. And I want to give you the least amount of medicine for the best results, and that's dependent on your feedback. So
So
talk to your
that's an,
physician. Mhm.
go ahead, sorry.
No, go ahead.
I was just going to say, so that partnership with the healthcare professional is very important, especially with treatment like botulinum toxin injections that needs to be repeated frequently.
Right.
Let's move to paralyzed vocal cords. Are there any new treatments for that? And is treatment dependent on the cause?
Uh, there's really aren't new treatments. I would say most of the treatments that I do have been around for a while. Um, yes and no to we to treating the cause. We need to know the cause, because if the cause is a type of injury that one could heal from, that kind of comes to play to how we look at things on the long term. For instance, if the nerve was cut in a trauma or something like that, then the likelihood of spontaneous improvement is low. We might intervene sooner with a more permanent type of treatment. If the cause of it is unknown, or it's something that we expect to uh, uh, improve over time, then we might wait before offering a more permanent type of procedure. There are a list of procedures that we do. These vary on where you are in relationship to the onset of the problem, meaning we might offer you a different procedure 1 month after a vocal fold paralysis versus a year after vocal fold paralysis. Most all the procedures are aim to do the same thing. Where the vocal when people have a paralysis and are symptomatic, their vocal cord is usually off to the side a little bit, and the valve that the vocal folds form come to when they come together, it's weak. So we're trying to strengthen that valve by pushing the weak vocal cord to the midline, so that the other vocal cord can contact it better. And that really that part of the treatment is really the same no matter what the cause is.
Okay. And there was a question regarding having a paralyzed right vocal cord and having a Gore-Tex graft,
Mm-hmm.
and that the person's still not happy with breathing and voice. Do you have any suggestions? And if you could speak a little bit about the Gore-Tex graft and the breathing issues with vocal cord paralysis, that would be great.
Sure. So, as said, we the for most patients, when we're treating a unilateral one-sided vocal cord paralysis, we try to push the vocal cord over to the midline. We could do that by placing a small implant underneath the vocal cord. We usually do that from the outside, so an incision is made on the neck. We open up the cartilage of the skeleton of the voice box, and we place a small piece of something underneath the cartilage to push the vocal cord over. That piece of something can be silastic, which actually refers to siliconized plastic, or kind of this medical grade plastic that we carve into a shape, or it could be Gore-Tex, which usually we make into a strip, or a well, it looks like a strip, or like a necktie or something like that, and then that's kind of folded upon itself and sort of placed in that space as an implant. Both are effective implants. There's not been a lot. Again, this happens to be sort of the way our literature works, but there's not a lot of good comparisons of saying that I could say one is better than the other. They both are effective and they both work. I do both myself, and they each have their advantages and disadvantages from a surgical perspective, meaning the way I do it, but from the voice outcomes, they both seem to work equivalent. If you are having problems with how you're doing after your procedure, obviously talk to your physician about that, and see what they think. Thyroplasty, or this operation that we do to move the vocal cord over, is successful depending on who what you read and who you talk to, 90 to 95% of the time, which sounds great and awesome, and we love high numbers like in the 90%. The unfortunate reality of that is that means 5 to 10% of the time it's not as effective as we want it to be. And so there are some patients that a revision perhaps might be offered to change things out or to do things differently. I didn't talk much about breathing. For most patients with a one-sided vocal cord paralysis, the main problem is with voice. Some patients can also fatigue with breathing, meaning if you have this leaky valve voice, you actually work hard breathing to kind of to use that voice. And so some patients will identify a breathing problem. From my perspective, most of the time that breathing problem is associated with that weak valve and is treated the same way. Again, there could be some exceptions.
And do you see swallowing issues also accompanying vocal cord paralysis?
Again, with one-sided vocal cord paralysis, yes, there can be swallowing issues. Depends how bad or where the vocal cord paralysis, where the nerve was injured sometimes. But the nerve to the voice box also is the nerve to the throat. So people can have weakness of their throat with a vocal cord paralysis. People also, because that valve of the voice box is weak, can have liquids sneak in there and choke on liquids more frequently. For many patients with a one-sided vocal cord paralysis, this can improve on its own, frankly, over time as your body sort of adjusts. Most patients with one-sided paralysis do reasonably well from a swallowing point of view. Again, there are exceptions. There are some patients who do quite poorly. And as I said, it kind of depends on the nature of the paralysis. For instance, a patient that had a stroke or had the nerve cut at we call it the skull base, where the nerve exits the brain. If you have a problem up there, then you can actually have more global problems such as that involve swallowing.
Anything else you want to add about vocal cord paralysis?
There's a lot we could talk about, but nothing in particular. I'd be happy to hear other questions if there are.
Okay. Actually, one quick question. The difference between paralysis and paresis.
Paresis is a word that means not complete paralysis. So paralysis means something is totally not working. Paresis means it's less than that, meaning it means it's somewhat working. From a prognostic point of view, if somebody presents with paresis versus paralysis, it's a better thing because it's less injured.
Okay. And does the treatment change then based on the activity of that vocal cord?
Yeah, I mean, the treatment is mostly based on the symptoms, and I would say the symptoms tend to be a little bit less with paresis. That said, you end up running into the same range of treatment options: voice therapy, what we call injection laryngoplasty, meaning injecting something to plump up the vocal cord; framework procedures, which refer to these implants or manipulating the position of the vocal cord; or reinnervation, where we actually plug a new nerve into the larynx where it's not working. Reinnervation is probably the one that you wouldn't do for paresis unless the patient is severely affected from that paresis, because you actually are cutting a nerve to do that.
Okay. So this is I think this might have been from a speech language pathologist, but the question is, what neuroanatomical or neurophysiological knowledge do you think is most overlooked by a speech language pathologist that you suggest further study on?
Not sure how to answer that. I mean, the speech language pathology, folks need to, or folks are trained in different aspects of neurophysiology, and I would say a lot of the speech language pathologists are used to treating patients with stroke, while some of those techniques can help our voice patients. A lot of the techniques in the voice side of the world are a little bit different. It's a specialized training. Most of our speech language pathologists learn what they do through training within a voice lab or a voice clinic, where we see these kinds of patients all the time, and through like kind of like all of our other training through mentorship of leaders who do this. I don't think I have a specific answer. I mean, the pathways are all the same from your brain to your larynx. No matter if it's a stroke problem or a voice problem, it's just how we access and do things with that.
Okay. And that was actually the last question. So I want to thank you for your time and knowledge and all that you do for not only our organization, but for the whole voice community. We really appreciate your dedication.
Well, thank you very much.